Hello, everyone. Thank you for tuning in today. Welcome to Time for More Injury Funding, the podcast for all who want to learn about legal funding and its significance in the personal injury, workers' compensation, medical malpractice, trucking law, rideshare, and many other types of law practice domains. I'm your host, Laura, founder and CEO of More Injury Funding, the legal funding counselors with passion for law, medicine, legal funding, and heart for all suffering individuals. In today's episode, I have an honor to talk to psychologist Michael Coupland. Let me tell you a little bit about Michael. He's the medical director of Virtually Calm. He co-founded three disability evaluation companies, conducted over 250,000 evaluations, and performed about 1,500 independent medical examinations. He developed the COPE, COPE with pain, and SWOP, SWOP programs, and authored a chapter in the AMA, American Medical Association, 6th edition guidelines. In 2014, Michael was named one of the top 50 people in workers' compensation by SEAK, SEAK. We will decipher these acronyms in just a moment so that will all make sense. Today, we'll be diving into a topic of behavioral health services for personal injury clients. At the end of our episode, I prepared a fun pop-up question for our guests, so stay tuned. Welcome to my show, Michael.
Thank you. Thanks for having me.
Absolutely. Can you share your journey into the field of psychology and what led you to join Virtually Calm as medical director? What is the vision behind your organization?
Sure. Thanks. I've been a psychologist since 1979. Started doing personal injury, IME, expert witness work in the mid 80s. Developed Canada's largest IME company along with a medical physician, and exited that and started the United States. Was invited to come to the US because of all the successes we'd had in Canada in the biopsychosocial model of treating injuries in an integrated manner. So I was invited to come often lecture in the US. People asked me to start something in the US. I started the United States' largest workers' compensation behavioral health company, exited that. Thought I was going to be retired, but I was attracted by the vision of telehealth. I retired just at the beginning of the pandemic, so I missed all of it and came back after telehealth was pretty well established. And Virtually Calm's mission is to provide telemental health to personal injury claimants in 46 states, to help evaluate patients, help them with their journey to recovery, also help with the claim resolution, and provide all those medical legal components of the case, which I'll go into as we discuss how the journey of the case goes. So that's the mission, is to be there for the claimants, but also to provide good evidence-based medicine for case resolution.
Thank you so much for explaining it so thoroughly. When we think of the impact of trauma, how can automobile accidents or any other traumatic events impact an individual's mental health?
Yeah, really good. And most people focus on the physical injury that occurs. I mean, especially if it's life-threatening, then of course, you can go to emergency and get all that taken care of. And often the physical part then leads to mental. So untreated pain, exposure to the traumatic event. Maybe somebody died in the incident. Maybe there was some brain injury, and even the type of brain injury that occurs in whiplash, the acceleration, deceleration type of injury that's unseen because there's no frontal trauma to the head. But all those sorts of things occur in slips and falls or in automobile accidents. And what I refer to as what is known as the biopsychosocial model. So the bio is the fact that there was some physical injury in many of these cases, the psychological impact from those physical injuries, or even just the exposure to trauma, and the social, the disruption of life, work disruption, social disruption, loss of family time, all the disruption to the family. And then the last piece I'd bring up about the biopsychosocial model that's really quite evidence-based is it can get a life of its own and develop into chronic pain. And that's where the central sensitized pain model has developed out of the biopsychosocial model to to explain with good evidence-based medicine why some people, and a lot of people, after an injury have psychological conditions arising from it. Very evidence-based, very well accepted in the literature now, and how we can present that, both educate the claimant about it, why you're feeling this way, also educate the reader of our reports, the attorneys on both sides, the finder of fact, if it's going to some sort of adjudication system.
Very, very interesting. Thank you so much for explaining all of these details here. What are some common behavioral health issues that rise in personal injury clients based on your lifelong experience?
Sure, I'd say by a big funnel, the number one is that the fact that there's a physical injury and there's going to be pain and social disruption arising from that. So you get anxiety and depression, adjustment disorders, they're called. Second is that there's going to be some brain injury. And the knowledge base about the acceleration, deceleration type of injuries where the brain shakes around, whiplash type of injury in automobiles and motorcycle accidents, slips and falls has become a lot more evident. Even though it doesn't show up on MRIs and CAT scans and such, it's there, and we have tools to identify that it's there. Next, it would be driving anxiety. So many people report to their physical medicine provider, my mother had to drive me to this appointment because I'm just too nervous to drive anymore after that accident. So driving anxiety. And then the post-traumatic stress disorder. So when life-threatening events occur, exposure to them, fear of death itself, it just has to, the perception that I'm going to die. Something's coming at you full bore, it creates something in your brain that stays there forever. And learning to cope with it and let it go is part of the PTSD treatment.
It's interesting you mentioned the driving anxiety. I meet so many people that I personally know who've been in really, really terrible automobile accidents that do experience that. So thank you for sharing this. Yeah. Now we will focus on recognizing symptoms. What signs or symptoms should individuals look for that may indicate they need mental health support following an injury?
Yeah, good question. We have lots of screening tools for it. And so these are often used by the physical medicine providers. And I'm going to talk about the points that they elaborate on so people, family, and friends can know about as well. Attorneys who aren't medical providers can know about it. But they're all signs of distress. So number one, again, would be the physical pain. So people have some anxiety. They have some depression. They feel hopeless. They're not sleeping well. They have type of thinking like this is never going to get better, what we call catastrophizing. They have a sense of perceived injustice. This is really unfair. It's somebody else's fault, especially when we get into accidents. They're always somebody's fault. And, these claimants are usually not the one at fault. That's why they've got a lawsuit, because they've gone against fault. And there's that attribution of what's called perceived injustice. So these sorts of things, if somebody is obsessing about these, that you're helping, you're trying to help, you're a case manager, if you're listening to this, or an attorney or a family friend or a claimant, and you're thinking about my own experience, those are the sorts of things. So that's on the physical pain side. And there's a tool with 10 questions called the Erebro scale that I've published about. It's been published over 100 studies that show that we can identify in as early as 2 weeks somebody who's going to be at risk of developing chronic pain from this. And we did a study with a large retailer in workers' compensation where we were able to identify, we did over 50,000 screenings, identified about 20% were at risk, and we intervened early with brief psychotherapy to help them with their coping skills and got really good resolution for helping them not devolve or go down into the spiral of chronic pain. The second would be PTSD. So if somebody's had exposure to a life-threatening event, there's a 6-question questionnaire called the PCL. It was developed for the military, but it's used to get a civilian version of it. 6 questions that get at some of the main symptoms of post-traumatic stress disorder. So the thinking, the affective, the cognitive, the sleep disturbance, the social isolation that occurs with post-traumatic stress disorder. So early screening for that. The biggest clue I'd say for people who are looking at somebody who might have PTSD is going to be sleep disturbance, the nightmares, the thinking about the event over and over. It just keeps going over in your mind. And then there's a screening for brain injury called the Neurobehavioral Symptom Inventory, 22 questions. And again, developed by the military. And it screens for the affective side of it, the cognitive side of it, the somatic and the headaches, and sensory, light sensitivity, things like that. So each of the main kind of symptom diagnostic clusters that arise from automobile accidents, personal injury, all have a screening tool and all have great measures to get into.
Very interesting. Wow, that's a lot of information to capture. But so do you utilize all of these tests for each client, or
It depends. What we prefer to do is look at what was the mechanism of injury. If it's just a pain, then let's do the Cerebro. If there was some brain injury, do the neurobehavioral symptom inventory. If there was some exposure, but good screening, like in a pain clinic or an injury clinic, would be great to do all these and screen for it, because the patient may not even remember all of the events because there was life-threatening things going on. They may not remember that maybe they have some concussion type exposure or trauma type exposure. So these screenings are good to do with patients, and we work with many physical medicine providers, and these are into their electronic health records to do these screenings and identify patients early. Now, I think this is fairly new to the world of personal injury. It's certainly old hat now to the world of workers' compensation or just general medical care, because they are so evidence-based to provide good outcomes. And providers get paid to do these screenings now in commercial health.
Good to know. Do you believe that friends and family members may help in recognizing these signs?
They're the first line of defense, really. You get a 20-year-old whose mother comes to the attorney's office with them. They're often a good source of the information because the patient themselves can't see them. There's a certain amount of denial. There's stigmatized. People feel stigmatized about, oh, I'm so anxious or depressed about this, and they're not sharing it. Men especially are not good at sharing it. They'll show it in different ways, like anger is the way that men often show their depression, and cultural differences. We know well that different cultures present pain in different ways to medical doctors and to psychologists. So that friends and family know the person best, and they can see changes in behavior and really bring these up to their case manager, their attorney, their doctor when they are seeing some change in behavior or sleep disruption.
Let's now shift our attention to integration of behavioral health services, therapy, and treatment. In your experience, how do therapy, medication, and psychiatric care contribute to the recovery process in personal injury clients?
It starts with a good assessment. Like anything, you have to start with the right diagnosis. So a good workup. So when, like you shared at the beginning, I've done over 250,000 evaluations in my network. We've probably done a few million evaluations with all of our psychologists and psychiatrists, and starts with a good diagnosis. So that work is worked up about their symptom cluster using testing, as well as the clinical interview, as well as collaborative interviews, especially if there's children involved. And with consent, you might get information from a teacher or their parents, of course, we interview. And so starting with a good assessment to get the right diagnosis. And then consider, especially in adults, if it's an aggravation or an exacerbation, a worsening or a permanent worsening of a pre-existing condition. And so that's important from the legal point of view, because the defense might be, oh, well, it's not caused by this, it was something else. But a good opinion, evidence-based about exacerbation or aggravation. Then typically we would try 8 to 12 sessions of cognitive behavioral therapy to help the patient with their coping skills, to learn to overcome what their symptoms are and adjust to them, whether they're like a disfigurement from an amputation or something. And then if it's not working, psychologists would refer to psychiatry for some medication management because some people just aren't sleeping well enough to do their psychotherapy. And so we've got to get them the help with SSRIs or sleeping medications with the psychiatric colleagues. And then we can start moving forward with their progress.
Mm-hmm. Can you explain how these behavioral health services can be integrated into a comprehensive treatment plan?
Yeah. Well, it's great when we work with the physical medicine providers. So a good accident injury clinic will often have either psychologists on speed dial or have a network in their team for it. The ideal model is to integrate it. And one of the benefits of us being a virtual model is that we can see the patient at the medical provider's office the same day as the visit. And this is so established as being a very positive path forward in integrated care that the American Medical Association developed billing codes for that. And the Medicare system developed payment systems for the physical medicine provider to get paid for the patient to be seen by a psychologist. It's called an originating fee. So that integrated care. So typically what happens is I'd be talking to you as my medical provider and say, I'm not sleeping. I'm so depressed. I'm hopeless. Well, let's walk you down the hall. I'm going to call up my psychologist colleague who's going to see and have a visit for you right here. And at the end of the visit, I'm going to walk back in with your consent, talk to the psychologist, and we're going to get a good plan together for you. Takes the weight off the medical provider having to deal with things that are out of their scope of practice and helps with the recovery. So that is how a good integrated model works. And with virtual care, it can happen the same day, instantaneously, seamlessly for the patient.
What a wonderful model there.
It really is.
And so how many providers do you have at your clinic or at your organization?
Well, we've got enough to cover the 46 states that we're in. Nice thing about virtual care as well is that my background, I told you I developed some really large networks. In our workers' compensation network in all 50 states, we had 1,500 psychologists and psychiatrists because it was face-to-face. Difficulty with that is that in some communities, there isn't a psychologist who really knows the world of personal injury or workers' compensation, and they knew how to be a good therapist, but they don't know all the innuendos of this. But with a virtual network, we've been able to take my best providers that I've worked with decades, and they can cover the whole state that they're licensed in. And some are multi-state licensed. And so the virtual network gives the best providers in this area and this scope of practice to the claimant and to the claim system. So we don't have to have a lot of them. We just have to have the best of them, which is what our mission is.
That's wonderful. Why, Michael, it is important for personal injury clients to seek behavioral health services early in their recovery. What benefits can early mental health intervention provide?
Well, a number of things. It's going to decrease their despair and their hopelessness. I mean, often at the first session, the goal is to give them some hope. To go from this is just hopeless, I don't think I'm ever going to get better, what I call the catastrophizing, the fear of moving, I'm just so tight, it hurts so much, I'm not going to move it, and the depression and anxiety, and give them hope. So most just, OMG, I feel so much better. And also to point out about the virtual care, most of our providers we get are bilingual. So we've got Spanish-speaking, native Spanish-speaking providers for people. And so then they decrease the symptom burden. The other side benefit is, I think most people who've been through the process know you can get litigation fatigue. It goes on and on and on, and it seems to be pretty hard to see the end in sight. Attorneys have been through a lot, case managers have been through a lot. This is the first time often for a claimant patient, and they can really use some support. So a certain degree, it'd be known as a claimant assistance program. It improves the stickiness to stick it through this litigation fatigue, have some hope, look at recovery, have goals in mind, and get to the other end of this whole claim and treatment process. So that, and it removes the burden from the case manager and the physician, medical providers who otherwise would be listening to a lot of concerns expressed by the patients. Now they have somebody's proverbial shoulder to cry on.
I love that. Thanks goodness they have you. Cross-disciplinary approach in treatment is essential. How do you and your medical professionals at Virtually Calm collaborate with attorneys and other medical professionals to ensure a holistic approach to treatment for personal injury clients?
Yeah, well, I'd say doing things like this. I mean, I'm really kudos to you to bringing this important feature to the knowledge base of personal injury attorneys. I'd say personal injury is the last horizon for the biopsychosocial model to get really accepted. It's in commercial health, and it's in Medicare, it's in workers' compensation, it's in evidence-based guidelines. But personal injury, it focuses so much on the physical that this has been neglected. So education, awareness to attorneys, to claimants, that number one, this help is available, that it does help, but it also fits into the claim settlement model. All of these factors that I've been discussing have economic impacts, and they need to be settled out within the framework of limits of claims and such, but they're real. And so they need to be addressed. So education, such as what you're doing today.
Can you, Michael, provide some examples of successful collaborations between body and mind in this case?
Yeah. So I'm going to talk about our workers' compensation experience, my workers' compensation experience as an example, that it has become so ingrained into showing better outcomes that it went from being a no-no that people, when they said in workers' compensation about 2010, if you brought up bringing psychology into workers' compensation, they'd go like this, no, no, no. But now it's the standard of care. And so these collaborations, as they're entering into personal injury, and the attorneys that are doing it, they may start at it at the sense of heart of where they're coming from because they care about their claimants. And that's where most personal injury claimants or attorneys start from. And then they say, well, this also, helps me with my settlement. And this also helps me with the stress of the burden of claimants who are having psychological problems on my caseload and impact on calls that I'm getting and such. So those collaborations tend to grow, tend to be self-reinforcing, and then lead to just these good outcomes.
How can mental health treatment and its effects be documented in personal injury claims? Is there a way to do that?
Well, the reports. So I always say to any of our providers, our reports have to educate, inform, show evidence base, cite all the symptoms, cite all the diagnostic criteria, so the reader of it might not even need a deposition. It's going to be so good that no deposition is going to be required because nothing needs to be explained. Now, people can always choose to have depositions, but a report should say it all. And so our reports are lengthy, filled with educational material. So there's something called the DSM, Diagnostic Statistical Manual. There's like 9 points for a diagnosis of depression. And we list them and then say, these are all, you need to have 5 out of 9 to meet the diagnosis. And here's the 5 out of 9, supported by the clinical examination, the testing, collaborative information, medical information. It's bulletproof by the time you get to reading the end of it. A defense attorney might be reading and saying, well, not going to need a deposition on this one.
Mm-hmm.
Everything's in there. I don't need to question this provider. So
Mm-hmm.
support the diagnosis. Secondly is explain the biopsychosocial model. So the biggest way that defense people get after claimants is on something called symptom magnification, symptom exaggeration, or outright malingering, which is lying in effect, but most is called symptom exaggeration. Well, the biopsychosocial model explains it differently. And I really believe in this model. I've used it for decades, that people with an injury just tend to catastrophize. They tend to have guarding behavior and fear of re-injury. It is so evidence-based. So in our reports, identify that model, and it really protects against an attorney going out and getting a symptom exaggeration defense IME, because it's been explained why this person maybe is treatment resistant or not recovering. It's not for the money, it's for the natural biopsychosocial model. So explaining the biopsychosocial model. The last part is the discharge summary. So placing the patient at MMI, maximum medical improvement, doing an impairment rating. Sometimes a surprise to people that there is an impairment rating for the mental and the TBI. There's a chapter in it. And as you mentioned earlier, I'm one of the authors of the guides section. And then look at the economic impacts of it as well. So the effect on working capacity, the effect on social capacities, and studies that show the burden, the economic burden, like PTSD was published in the American Psychiatric Association on hundreds of thousands of cases, having an impact of about $19,000 on their lifetime future cost of care. So establishing the future cost of care, but also putting the documentation that supports that this isn't just this person, but this is a population-based evidence.
Mm-hmm. What role does mental health play in the legal process for these clients?
Well, the nice thing is that we are a fact witness. Our providers are not a hired gun expert witness. We're there treating the patient. And often the finder of fact will give more weight to our testimony because we are unbiased. We are treating the patient for their best outcome. We're there for the patient. We're not hired by defense or plaintiff counsel. We're there for the patient. So our opinions tend to be highly valued. Plus, we've given a lot of evidence in our reports for the finder of fact who might be reading the reports at a preparation in a trial. And we're part of the journey for the claimant. So, helping with the claim settlement process, helping with their, as I said, stickiness to see it through, and taking the burden off the team, and really helping the patient with their coping.
Mm. As the medical director of Virtually Calm, Michael, what advantages do you see in providing mental health services virtually, especially for personal injury clients? How does this format enhance accessibility, and does it enhance it at all?
Absolutely, that does. The benefit is that we have no wait times because virtual is great. We have no travel time for patients. There's no cost of, the Uber ride or taxi ride to get to the appointment, and going through Los Angeles traffic at rush hour. I'd often look at the map and say, well, our claimant's only 6 miles from there. They say locally that's a 2-hour drive, right?
That sounds
So
also like Atlanta, Georgia.
yeah,
Uh-huh.
yeah. The ring around Atlanta, it can take
Mm-hmm.
forever just to go a few miles. So it
Mm-hmm.
takes a lot of burden off. So it makes it easy, and it also makes it accessible, easy, and we have the best providers. We really have really good providers that we can attract to this, and they can cover the whole state they're licensed in.
And we'll share your company's information later on in this show. Michael, what challenges do you encounter in delivering virtual behavioral health sciences, and how do you help clients to ensure effective treatment?
So number one is technology. I mean, it is a technology, so they have to have an app, phone, an internet capable phone or computer or tablet, something like that. I mean, we can do phone calls only, but we really prefer to see the patient, and that's the majority of them. The other challenge is that if there's lists of providers that people are looking for, saying, well, I need a psychiatrist in North Atlanta, and they look at us and we're only there in one location where our main office is in Georgia and it's over in Savannah or somewhere, and we're not looked up in there. They have to look at the virtual list. So that's one thing, as people might be listening. Look for the virtual list instead of your geographical list for options, because we can treat anywhere in that state.
That's I'm glad you brought this up to the attention. Michael, let's think about some case studies. Can you share a success story from your practice that highlights the positive impact of behavioral health services on personal injury client? What challenges did you face in this particular case, and how did your patient receive recovery?
Yeah, so I'm going to talk about a whiplash case. Very little physical injury, but was a 25, 30 mile an hour rear ender. So the documentation was that of that accident, and the symptoms they were presenting with: mental fog, some headaches, some light sensitivity, some driving anxiety. They were treating at Cairo for their whiplash neck and subluxation type of injuries. But the Cairo had identified that they could probably benefit from some concussion treatment. So they were tested, and it was confirmed that they had an acceleration, deceleration concussion. There is a very established cognitive behavioral therapy. Cognitive behavioral therapy is to change the way you're thinking, change some of your behavior. So they were given activity pacing. They were giving psychoeducation, because most people, we have to educate them, you will recover from a concussion. Cognitive restructuring from the OMG, I'm never going to get better, to positive thinking, I will get better. And they did recover fully at MMI. No impairment, fully back to work. But the documentation at the end did validate that they had that injury, had those impairments, had a disruption in their work life and in their social life. And even their spouse had to stay home more to take care of the child, because they had been working opposite shifts, like many couples. One worked morning shift, one worked afternoon shift, so they could manage their childcare together, and that got disrupted. And so all of those things were documented for helping the resolution of the case. The other one that came to mind was post-traumatic stress disorder. So a fellow driving a big Ford truck, driving through an intersection, got hit by somebody who ran the red light and slammed into him. Being in a big truck, hardly any injuries at all, but somebody was killed in the other car. Catastrophic for that individual. They had what's called survivor's guilt type of PTSD. They weren't to blame for the accident, no fault at all, but the mind doesn't think about it that way. And so they really had a lot of what's called hypervigilance. They were just jumpy all the time. They weren't sleeping. They couldn't work. They tried cognitive behavioral therapy, but they were too just hypervigilant to attend to therapy. So they had to get medication management. So we added psychiatric, but still they were treatment resistant. Not everybody recovers. 20 to 30% do not recover from post-traumatic stress disorder. And it was really able to identify that this patient was going to have some permanent post-traumatic stress disorder impairments. So at the end, they were put at MMI, meaning, MMI doesn't mean you're all better. MMI means no more treatment is going to lead to further functional recovery. And that's when we rate impairment ratings. So they got a 10% AMA impairment rating. They got permanent work restrictions because they were driving their truck to and from work and going to different job sites all the time. And they couldn't do that anymore.
Thank you, Michael, so much.
And also the provider who had done this done really good reports that it was able to rebut any kind of defense IME and show that up in their deposition.
Mm-hmm. I appreciate you offering these insights into these sad and beautiful stories. Let's talk about the future for a moment. What trends or innovations do you see emerging in the field of behavioral health that could potentially benefit personal injury clients in the future?
The biggest developments right now are in what's called interventional psychiatry. That's where some physical medicine types of interventions are having a positive impact on brain recovery. So, transmagnetic stimulation, TMS, for depression. So, magnets are put in and send pulses towards the brain. And so, it's for what's called treatment resistant depression. And something called stellate ganglion blocks. They're an injection into the stellate. They've been used for a long time for things like complex regional pain syndrome and other pain factors. So pain management doctors do it, but it's also being used in the military for post-traumatic stress disorder. Firefighter departments are using it. And the nice thing about personal injury, it's not subject to some of the guidelines that commercial health have that restrict and limit these newer emerging therapies. And so we can offer these in the personal injury area.
Mm-hmm. Mm-hmm. How is Virtually Calm adapting to these changes? Or are you guys adapting?
Yeah, we are. So we will make recommendations for these types of therapies as appropriate for the treatment resistant cases. And then we don't provide these because these have to be done face to face, but we can refer to that. And we've got a network of providers that can do these interventions and help with the patient's recovery.
Mm-hmm, mm-hmm. That's wonderful. For individuals who have recently experienced a traumatic injury and are unsure about seeking help, what advice would you give to them? How can they begin their journey towards recovery?
Have to speak up. I mean, have to set aside the feeling of hopelessness and stigmatization, maybe some cultural sort of barriers to I just got to suck it up kind of approach to it, and speak to your case manager or your family member to speak up for you or your medical provider and ask for help. Really encourage you to ask for help.
Mm-hmm. Michael, so finally, what would you say is a key message that you would like to convey to personal injury clients regarding the importance of behavioral, health, and how it is needed to overall recovery for personal injury clients?
I think speaking to the claimants, it can help. Whether you're having mental fog, anxiety, depression, can't work, we are there to provide you solutions, strategies to cope, to overcome what you're struggling with, and get back on the road to recovery. Pain, whatever it is, we've got solutions for it. And then if you're a personal injury attorney or the claimant wondering, oh, let's do anything also to help with my settlement, if you've got that perceived injustice side of things going on, that this wasn't my fault that I can't work and I've got all these, then yeah, we're going to provide the evidence-based medicine to support your claim and show the quantification of damages that arises from mental health impairments.
Mm-hmm. This was so great. I hope our discussion about behavioral health services for personal injury clients was informative and educational. As promised, here's one pop-up question for you, Michael. Are you ready?
Sure, what is it?
All right. Do you have a quirky routine or a superstition you follow before a big meeting or an event?
Well, anybody who's looked at my bio might see that I've done 300 conferences
Oh,
on
goodness.
mental health and injuries. And so what I do is not think about it at all the day of the presentation. I prepare in advance, but my way of doing it is to walk right in and just shoot from the hip, so to speak. And I'm glad that you allowed me to do that.
I love it. If anyone has question related to trauma caused by personal injury or needs a psychologist help, how can they locate you and virtually call?
Well, the website's virtuallycalmus.com, and I welcome attorneys with a question to call me directly. 250 area code 265-1143, and we can chat about it. I love what I do and love helping claimants with their recovery and educating attorneys about the benefits of mental health care for personal injury.
I love it. Thank you so much. That was psychologist Michael Coupland with Virtually Calm. I want to thank you all for listening and watching our story today. For more tips and tricks on legal funding and personal injury law and medicine related topics, follow me, download, like, and subscribe for It's Time for More Injury Funding on several podcast platforms worldwide. And follow More Injury Funding on LinkedIn, Instagram, Facebook, Twitter, TikTok, Pinterest, YouTube, Google Business Profile, and my website at moreinjuryfunding.com. I can wait to see you, my dear listeners and viewers, on my next upcoming episode. Until then, be well. Thank you.
Bye now. Thank you.